So you may want to record
right now. Okay, I'm going to go ahead and press the record button. Good. Let's make sure. I think we might be live.
Yeah, it says it's live on the upper.
Live.
Do you? Okay, I see. Go ahead.
I guess we can go to Facebook and see, right?
Yes. Okay. We're good. I checked. We're live. I'm not sure if we're going to be able to see the comments here. Hello, everybody. Happy Friday. I will keep my phone close by, so if anybody makes a comment, I'll be able to see. So welcome, everyone. I'm so excited about this talk today. We have the incredible Dr. Simmons and the amazing Nicole. I am not sure if you guys can see what I'm seeing, so hopefully I'm pointing to the right place. So I'm just going to introduce them really quickly to you guys. Dr. Simmons is triple board certified by the American Board of Clinical Neurophysiology, American Board of Psychiatry and Neurology, and American Board of Sleep Medicine. He is the founding director of Comprehensive Sleep Medicine Associates located in Texas with offices in Houston and Austin, and also providing telemedicine services to patients out of state. He also is the founding director of the Sleep Education Consortium that provides education to healthcare providers. He's involved with many research activities and sits on the board of other sleep-related organizations. Nicole founded the San Diego Center for Speech Therapy and Myofunctional Therapy in 2003. She's one of only 3 speech-language pathologists in San Diego County who holds a joint certification as a Certified Orofacial Myologist through the International Association of Orofacial Myology. Can I get a round of applause? Thank you guys. Thank you for being here. If I missed anything, you guys are welcome to add to that.
That's fine. Great. Thank you. It's a pleasure to be here.
Of course. So our topic today is airway, sleep, and beyond. We're going to let Dr. Simmons start, or actually we're going to have Nicole tell her story first, and then Dr. Simmons has some amazing things to show us today. So go ahead, Nicole.
Sounds great. Well, Renata already complimented my diastema. So as I'm talking, you'll see the huge space between my front 2 teeth that was not there a couple weeks ago. So thanks for the music, Dr. Simmons. So I am undergoing maxillary skeletal expansion right now, treating my own airway issues. And I'll just give a little introduction about how I discovered that I have upper airway resistance syndrome and how I met Dr. Simmons, who really changed my life. So my son has sleep apnea, or he actually had sleep apnea that I discovered when he was 2 years old. So that sort of set me on this airway quest and journey that probably a lot of other people listening are part of as well, with themselves or members of their family, definitely patients. And as I'm learning about upper airway resistance syndrome, taking courses, I'm realizing, this kind of sounds a lot like me. So a history of headaches, migraines that started getting worse as I got older. I always had anxiety, always had stomach ache issues, just like anxiety-based stomach aches. I started getting the stomach ache when I woke up every morning. This just like pit in my stomach that would only go away the minute I stood up and started walking around. And it was just painful and weird. I later came to realize it's reflux due to negative pressure in the airway when sleeping. History of depression, not treated with medication or anything, but I'd always wake up feeling depressed, like this weight, like what is wrong? And nothing was wrong. And I just could not figure out why I would always have this. I am always high energy, high sympathetic tone. Even in college, I started getting some panic attacks because kind of like the straw that broke the camel's back when you're already sort of having poor quality sleep and then you're not getting enough sleep in college. Little things can put you over the edge. So that started occurring. When I got pregnant with my first son, I developed gestational diabetes. I had to take nutrition classes through the hospital. That's what happens when you get diagnosed with diabetes. And I had to be put on insulin. And it was very weird. I was the 1 out of 5 people in the class that was not significantly obese. And I'm looking around thinking, why do I have diabetes? This is so weird. And I had to inject insulin in my stomach every night before bed the last few months of my pregnancy. And they just said it's just due to, hormones. And nobody thought that I was having poor quality sleep. It's important to know I do not snore. I'm not a snorer, and I'm not even a mouth breather. You don't have to snore to have abnormal sleep. You do not have to have mouth breathing to have airway collapse. So anyways, my other history is I can fall asleep in 2 seconds. I think of it as a great skill. Lights go out, I'm asleep immediately. There's a family joke. I've never sat through a movie because I will fall asleep immediately. So that's another sign that I'm probably overly tired, although all day I'm moving at the gym, keeping myself busy. I'm also an accessory breather. So a lot of upper tension, a lot of poor forward head posture. So all these things kind of were signs. Sometimes I'd wake up in the middle of the night with my heart pounding, sometimes gasping for air. I started getting like some heart palpitations throughout the day at times, these signs and symptoms. And I had a cortisol test, a saliva test that said, you're borderline adrenal fatigue. And I'm like thinking, this is crazy. So I look back on my history as a child, and I was class 2 malocclusion, narrow palate, not treated with expansion. I had a headgear as a child, tongue tie that wasn't diagnosed. I look at photos and my mouth is wide open with these huge infraorbital venous pooling. I was very impulsive as a kid, and I had significant night terrors all the time, and sleep talking. And I would have these dreams that would end abruptly in fear. So I would just like wake up out of a dream startled. And that would happen a lot as a child, and just a very anxious child. Couldn't leave the house without having Pepto-Bismol pills, those little pink pills in my pocket, because I was so nervous I would always get a stomachache. So anyways, that was kind of life. And a dentist here in San Diego did an HRPO on me. And we discovered through the HRPO that my heart rate was just shooting up above 100 all throughout the night, like I was running a race in my sleep. So I decided to get a sleep study here in San Diego. After learning about upper airway resistance syndrome, I called all the labs I could find to find someone who will test for the RDI, the respiratory distress index. Found a lab, said they do. I paid cash, out of network, $1,000, and my sleep study comes back with AHI 0, RDI 0, 53 spontaneous arousals in my 6 hours of sleep, but they're just spontaneous. Really what the recommendation was is no sleep disorder. You just should get cognitive behavioral therapy for insomnia. And I said, I don't have insomnia. I could fall asleep in a split second. This is so weird, but I honestly felt relieved that I did not have sleep apnea, and I wanted to go out and celebrate. Woo, off the hook. I'm good to go. Until I heard Dr. Simmons lecture at the AAPMD in Las Vegas, and he talked about upper airway resistance syndrome, which I know he's going to discuss. And then I thought, oh my gosh, I think I have a problem, and my sleep study was not scored correctly. So I ended up emailing Dr. Guilleminault, who's like the father of sleep apnea. And fortunately, he wrote back. I titled my email, "Help, I think I have upper airway resistance syndrome," and I capitalized it. And he actually wrote back. And he saw that the person that was the doctor who did my sleep study was one of his residents at Stanford a couple years prior. So we actually had them rescore my sleep study. And they gave me an AHI 5, I guess, just to qualify me as sleep apnea. It was all the template report. It was very clear. It wasn't really rescored. And I learned that I need to fly up to Texas to see Dr. Simmons to get the PES sleep study with pharyngeal esophageal manometry, which is the only or the gold standard for diagnosing sleep disorder breathing in terms of upper airway resistance syndrome, which he will discuss. So I did get that sleep study, and that's where the answer was. And that's where my life changed, because there was an answer. I had, and he'll go over this, but my AHI, when you look at not just oxygen, but disregard that, and let's look at the fragmentations in sleep. When my brain is aroused due to me working harder to breathe, my AHI was actually 21.4. My RDI was 33.6, which means every 2 minutes throughout the night, my brain is getting pulled out of its sleep cycle. Wow, that's the reason all of these other symptoms. So Dr. Simmons put me on CPAP as a trial to see how I would feel. And I did fight it, and I did not want to do a CPAP. I threw it off the first night. Forget this. There's no way I'm 40. Well, at that time, I guess I was 40 because now I'm 42. I'm 40 years old. I am not going to have this machine with a hose and all this, sleep. It was so uncomfortable. And he worked with me and didn't stress me out about it, but said, let's just do it as a trial to see how you feel. And I got a comfortable nasal mask, and it actually was sort of comfortable. And all of my symptoms pretty much disappeared on the CPAP. No, I haven't had a stomach ache in about 2 years, except honestly, when I haven't worn it. Headaches gone. I would have chronic headaches, like that would last 3 or 4 days, gone. I thought I was lactose intolerant. I could drink milkshakes and malts up the wazoo. I'm good to go, which is not a good thing, actually. My blood test results changed. I was sort of borderline diabetes, and now it's not even a concern. Cholesterol dropped. Basically all my symptoms disappeared. So it's been a really amazing journey. And I got the maxillary skeletal expansion and the suture split just a couple of weeks ago. So I'm going through that portion of the treatment to see, for me, the alternative to CPAP, can we fix this skeletally? So that's my story. And I thank Dr. Simmons because he really changed my life, and all of the people I work with, it's like a totally different perspective now. And there are so many people suffering who are undiagnosed or even misdiagnosed that are going to all these doctors, psychologists looking for answers when the answer is completely different, and who are getting sleep studies and they're being scored, incorrectly, basically. So I'll stop there, but that's my story.
I do have a quick question.
Mhm.
Did you have the dome procedure done?
No, I just had
Okay.
MSc, and I'm sometimes spitting as I'm talking. It's been an interesting process. I just had cortipunctures. So
Okay.
I don't know if it's like a sort of rule, but it seems like when you're over the age of 40, you might need cortipuncture. So I had 18 punctures along the midline to loosen the suture. And then there's 4 screws for the MSc. And I, turned the screws, and the suture did split. And immediately my nasal, and I'm not a mouth breather, so it's interesting, but nasal airway opened up substantially to the point where when I was wearing
Wow.
CPAP, it actually felt like the pressure was too high. And I haven't worn the CPAP since the suture split. And I'm feeling pretty good. It's still, I'm still trying to figure things out.
Well, tilt your head back.
Okay, so I have a flashlight, because who doesn't have a flashlight next to them?
Oh my goodness, that
Can you
is
see?
awesome.
So they just cut off the arms of the appliance last week, and then they're going to close the gap with Invisalign. But I've gotten I believe it's about 4 millimeters of expansion along the midline, and we know, based on laws of physics, I believe it's like Puiseu's law or whatever, any small increase in space in the nasal airways to the power of 4, I believe is what it is. So small changes are really significant. And my orthodontist thinks we'll get another millimeter or millimeter and a half or so. And then all my teeth, based on my old orthodontics, were tipped out. So I actually have I had a perfect bite, it looked great. But on a CBCT imaging, I actually had a skeletal crossbite. My upper jaw was more narrow than my lower, but my teeth were tipped out, so it looked totally fine. So the orthodontist is going to upright my teeth in the bone. If this doesn't work, my options would be CPAP or potentially MMA surgery, because my jaws are, you can't tell without imaging, but they are retruded. I was treated with headgear that didn't obviously grow things forward. And so I do have AP deficiency, but this is kind of like step 1, trial number 1, but I definitely feel better. I'm not waking with any stomach aches, not really headaches right now. So we'll see. It's a process.
Fantastic.
With a normal sleep study.
Right. So what I need to do is, I need to go and get another sleep study also, because I do want to do that to see.
But the original one, being normal. So that, what you see,
I hear what you're saying. Yeah.
what you see depends on how you look. It really comes down to that, and, I can say, are all myofunctional therapists the same? Are all dentists the same? Are all hairdressers the same? Are all chefs the same? Well, all sleep centers are not the same. And it's really, and not all sleep specialists are the same. And not everyone's approach to this is the same, which is unfortunate. And clearly there are a lot of things happening to try to standardize the performance of sleep testing on a national level. But when they try to standardize things, unfortunately, the standard isn't always the highest standard. It's almost sort of like a common denominator, low standard that everyone can achieve. And not everyone is as involved in the field that practices sleep medicine as we are at Comprehensive Sleep. And not everyone will look at the subtleties that are going on, which is unfortunate. So I'm up for questions.
Awesome. I have a bunch over here from people whenever we're talking. So the whole reason why you're here today is because on our closed Facebook group, we were talking about narcolepsy. And then everybody started asking, who can come talk to us about narcolepsy? And Nicole said, I know the guy.
Okay.
So we do have some questions about that. Angela asked, how early can narcolepsy be detected?
Well, that's a good question. Clearly, there are children as young as 5, 6, 7, 8 years old that have been diagnosed with narcolepsy. But that's not typical. Typically, it's going to develop during late teenage years, and maybe early adulthood. But usually, it's going to be during teenage years. There's so I guess let's talk about what's the question. Let's start off with the question: what is narcolepsy? And what narcolepsy is today, by definition, may be a little different than what it may be in the future. But it's been historically thought of as a disorder of REM sleep that's associated with excessive daytime sleepiness. There are a lot of things that are associated with excessive daytime sleepiness. Sleep apnea can cause excessive daytime sleepiness. So if you're looking at sleepiness, and if you're defining someone that's sleepy as being narcoleptic, that's not necessarily the proper way to use the term. So narcolepsy is considered a disorder, a central neurologic disorder of an increased propensity to fall asleep, not due to the fragmentation of sleep at night, not due to sleep apnea, not due to leg twitching movements, but because the brain has a difficulty in the regulation between wake and sleep. And so there's increased sleep intrusions, and also there'll be increased wake intrusions and down the road as the condition progresses. But it's a disorder of REM sleep. REM sleep is only one stage of sleep that has very specific features. People think it's the most important. It really isn't the most important. Slow wave sleep actually for growth and development, may actually have a more important role than REM sleep. But REM sleep is when your body is paralyzed, but your mind is actively hallucinating. So you're actively dreaming and your eyes are rapidly moving, probably in connection to the hallucinations you're seeing. And at the same time, your body is paralyzed. Now, people that have narcolepsy go into REM sleep too quickly. So they fall asleep and they go into REM. And sometimes they'll go into REM right as they're falling asleep. So they'll start dreaming right as they fall asleep, and they may not even be fully asleep yet. And they're having these hallucinations. And we call those hypnagogic hallucinations. So that's a sign of someone going right into REM. So they're dozing off. Let's say they're in class. They're dozing off, their eyes are starting to shut, and all of a sudden they're hallucinating that all the stuff is going on in the classroom. They come out of it, none of it's going on. They realize that they're hallucinating. Another part of narcolepsy is something called sleep paralysis. That's when you wake up in the morning, but you can't move. And it's actually pretty scary. The person sits there for about a minute trying to move, and they can't. And they feel like, oh my God, did they have, they feel like maybe they had a stroke. Again, that is the sleep paralysis that's only supposed to be present during REM sleep. But if it continues while the person wakes up, that's abnormal, and that's a sign of narcolepsy. Although there are people that will have sleep paralysis that do not have narcolepsy. There have been some estimates that about 70% of the population may have at least one episode of sleep paralysis in their life. But when it becomes a common phenomena and it's associated with daytime sleepiness, it's pointing towards narcolepsy. Then the other feature that is probably the most specific feature for narcolepsy is something called cataplexy. And that's when your muscles just give out and you sort of fall to the ground. Sometimes it can be very subtle and it just be the head bobs down or someone drops something. It's usually triggered by an emotional event. What that is the activation of the sleep paralysis system that we talked about. That's only supposed to be present during REM sleep, but when it becomes triggered or activated during the day, that causes cataplexy. That's the most specific feature of narcolepsy, because sleep paralysis or hypnagogic hallucinations, those can cause, because in other conditions, even people that are sleep deprived may actually have some of those symptoms, but cataplexy is very specific. So if you step back now and realize that the brain or the central nervous system has a certain propensity towards falling asleep, all right? And as you're awake throughout the day, that propensity increases. And then at nighttime, it's very strong and you fall off to sleep. And then as you're asleep, it gets weaker and weaker. And then when you wake up, it's very weak and it's easily overtaken by the activation of your wake system. So there's constantly a balance going on between your sleepiness and your wakefulness. Some people have an enhanced sleep drive mechanism. Narcoleptic patients are an example of people that have this enhanced sleep drive mechanism. There are some people that have an enhanced sleep drive mechanism for reasons we don't understand, and we call that idiopathic hypersomnolence. So those individuals are very sleepy during the day. So what distinguishes an idiopathic hypersomnolent patient from someone that has narcolepsy? Well, they may not have those other features I talked about, except for being very sleepy. But there's this test called the multiple sleep latency test that we do during the day. And we test to see if someone could fall asleep quickly. And then if they do they go into REM sleep? And we basically have 4 or 5 napping sessions during the day. Unfortunately, the insurance industry is a strong driving force for what we are allowed to do when it comes to treatment. I shouldn't say allowed, what they're going to pay for. And there are some excellent medicines that have come out in the last few years for treating narcolepsy. But those medicines probably also work for other conditions of excessive sleepiness, such as idiopathic hypersomnolence, but they have not yet been actually FDA approved for those conditions. So when you're doing the multiple sleep latency test, we're looking to see if someone goes into REM sleep. But sometimes they may only go into a piece of REM sleep. It's not clear cut like in the middle of the night when they're in REM, but they are having a few little rapid eye movements and their muscle tone drops a little bit. So if you look real closely, there's there's components of REM sleep, and this person's very sleepy and we can't find any other reason to why they're sleepy. Maybe they have narcolepsy. So I propose that there's a spectrum of clear-cut classic tightly related to REM narcolepsy, which we call type 1 narcolepsy. And there's type 2 where we don't have all those features. We don't have cataplexy, but the multiple sleep latency shows REM. And then there's others that are just the excessive sleepiness, but it's not really tied to REM. But all 3 of those are centrally mediated hypersomnolent conditions. So it may be almost easier to think of them as all narcolepsies. And I think idiopathic hypersomnolence should probably be considered a type of narcolepsy. I only throw that in there just because it's a spectrum. Things aren't always black and white and so clean, with exact dividers between them. And so hopefully I've addressed your—
That was perfect. Seriously, I know that we're not going to be able to get to everything that we want to ask you today, so we're going to have a second one, if that's okay with you guys. Sure. But Angela also asked, what are the signs we should be looking for or questions we can ask our patients? Is there a specific questionnaire that is available for Airway providers for narcolepsy? I think you answered the first one already.
Well, if you actually, the questionnaire that I developed years ago that we use in Comprehensive Sleep Medicine Associates It covers airway, narcolepsy, parasomnias, restless leg syndrome. It's a one-page questionnaire. If you go to our website, I'll put up the web address later, but it's basically csma.clinic. CSMA for Comprehensive Sleep Medicine Associates, and you can go to our list of questions. But it's so there are, like I said, narcolepsy questions. I mean, there are. The question is, how long does someone want to spend filling out the questionnaire? So there are quite a number of them, but most importantly, I think that if someone has excessive sleepiness, it's important to realize that airway is extremely common. Statistically speaking, one of the most common causes for excessive sleepiness, but by no means is it the only thing. And when someone is having their airway treated, that's been found to have an airway problem, and they continue to have daytime sleepiness, they clearly need to be in under someone's care that has a broad perspective and is looking for periodic leg movement disorder, narcolepsy, or it could even just be poor sleep hygiene. Up at 3 o'clock in the morning sending emails.
She knows nothing about that.
It's just happened recently. I used to always wake up like that and just completely be completely awake before I started Myo. And I thought it was just insomnia, but I really think it was UARS. But the past week it's happened a couple of times, and I think it's just stress. But it'll go away. Let's see. Jacqueline asked, what are the negative impacts and what health risks are involved with narcolepsy?
Well, with narcolepsy, there's a lot of patients will have other conditions. Frequently, they'll be misdiagnosed. Most patients with narcolepsy,
next question.
If they're going to get diagnosed properly, and I'll say that most patients with narcolepsy are still being missed. Right now, statistics say there's maybe 1 out of every 2,000 people might have narcolepsy. But it may be even more common than that, especially when you start thinking about the spectrum. Spectrums of conditions are important. And when we talk about airway, hopefully we have time to talk about upper airway resistance syndrome, because it's part of a spectrum of breathing issues. And again, where do you create the lines? But let's go back to the question. A lot of these patients have been diagnosed with depression. Right? And it's a lot of times people are misinterpreting the lack of energy and the lack of success in carrying things out in someone who might be intelligent, but just can't maintain the focus to get the job done or to get school done. And then as they start to fall off the productivity curve, they're getting depressed as a secondary phenomenon because of their inability to perform, yet they know that they have the intelligence to understand. And so depression, bipolar, headaches seem to be very common in the narcoleptic patients. But narcolepsy, other than those issues, I mean, narcolepsy, it's going to cause excessive sleepiness. And obviously that can result in motor vehicle accidents, just things that are related to just falling asleep while performing a task. But let's talk about airway, because the airway is under neuromuscular control due to pharyngeal muscle tone and the mandible and all the muscles that are controlling the mandible, including the masseter. And excessive sleepiness and sleep deprivation, for example, has been shown to decrease muscle tone when someone falls asleep. So let's say you stay up for 36 hours and then you go to sleep. There's a higher likelihood that you're going to snore if you have a partially compromised airway. Whereas if you catch up from all your sleep and you're not sleep deprived anymore, when you go to sleep, you're less likely, your snoring may improve. So sleep deprivation changes the muscle tone of the upper airway, resulting in a relaxation of that muscle tone and a narrowing of the airway. So when you're breathing through a smaller space, you're going to have more of a vacuum, and because you're trying to get the same amount of air through a smaller space in something called the Bernoulli effect, with the Venturi forces are involved, and basically the soft tissue starts to vibrate, causing snoring. So we know that there is a higher occurrence of sleep apnea in the narcoleptic population than the general population. There have been studies that say maybe 25% of narcoleptic patients may have sleep apnea. Well, it depends on how you define sleep apnea. In my experience, I would say it's closer to 70% of patients with narcolepsy have obstructive sleep apnea, or at least to the level of the upper airway resistance syndrome. So there is some degree of airway compromise. And the question is that a result of the hypersomnolence of the neuromuscular control of their airway? And it may very well be. Hopefully that sort of answered the question.
Definitely. We have a few more questions on that, but I think that you touched on the most important points on narcolepsy. So let's go into UARS. I know you have some slides to show us.
Mm-hmm.
I will start just with a question. Nicole put some amazing questions together. Thank you, Nicole. Why do so many people get missed in the diagnosis of upper airway resistance syndrome?
Well, if you're not looking for something, you're not going to find it. And so many people have this misperception that sleep apnea is all about the oxygen level. And when you hear them talk, they rattle it up. Someone went to a lecture and now all of a sudden they're an expert, because a light bulb went on. It's like, wow, oh my God, there's this breathing problem. And then they start talking about, oh, you're not getting oxygen to your brain. And that's the problem. I mean, sure, that can't happen. But if that becomes your threshold, then whenever there is not a drop in the oxygen, people then think, oh, there's not a problem. And that's the problem that I have when people are using oxygen as the sort of the mechanism involved with the abnormality of sleep apnea. So let me just show you briefly here. I need to be, if you can allow me to share my screen. Okay.
Let's see if that will allow you.
All right, so 1 second here.
Let me see if that worked.
Yes. Okay, so here we go. All right. You see my screen?
Yep.
All right.
Beautiful.
So this is a sleep study. All right. And let me get my little laser pointer. Here you see. Okay. So these are brainwave channels. These are 2 channels for eye movement. Here, these are all EMG or muscle channels on the face, because we're looking at all the external muscles of mastication, basically to characterize the bruxing phenomena. This is more EMG than you see in most sleep studies. This is the ECG, or the heartbeat. These are limb movement channels. This is a microphone for snoring. Here's airflow through the nose and mouth measured 2 different ways. One of them is with a little cannula looking at pressure. The other is looking at temperature. It's a thermistor. Then you get movement of the chest and movement of the abdomen. All right, so here's an arousal right here in the brain waves, right here. What's causing that arousal? Not really clear. Oxygen is staying right around 96, 97, 90. It's not really moving, but here is the esophageal pressure catheter. Okay, so this is a catheter that goes down someone's nose, and they basically, I have a picture showing someone having it inserted, but it's a soft little mylar feeding tube catheter that's hooked up to a pressure transducer outside of the patient. So we're measuring the pressure inside the chest, basically. So as the upper airway becomes more collapsed, there's more negative pressure that's going to be exerted during inspiration. This is the most sensitive measurement of respiratory effort, right? And you could see how the magnitude of the signal is much higher. And here's the arousal. Then here, with the arousal, the upper airway opens up, and now there's not as much negative pressure. So now the person can breathe, and they don't have to pull as much. So here, this person's pulling about close to -20, about -15 to -20 centimeters of water pressure. And here, now they're pulling to -5 after the arousal. So this is a respiratory effort related arousal. Okay. I mean, you can even say, well, maybe it's even a hypopnea, because if you look at some of the current definitions of hypopnea, is that if there's a change in a hypopnea sensor. So if we call this a hypopnea sensor, as going on for 10 seconds leading to an arousal, then that can be called a hypopnea. Clearly that's going to be missed by 99% of sleep labs. All right, here's another example. I mean, once you put the catheter, it becomes clear cut, but now you can see a real subtle change right here. But by definition, it says it's got to go, it has to be 10 seconds. Well, maybe that's a little shy. If you're calling that a normal breath, then you're going to say, no, it's just shy of 10 seconds, but clearly causes an arousal. So do you score it or not? All right, here's another case. So some people might say, okay, I really see a hypopnea here. Sure, a lot of labs will miss that. Look, the oxygen's 97.7, 97, it doesn't change. It's not about oxygen. It's about arousal caused by increased respiratory effort. That's a respiratory effort related arousal causing disruption to sleep, all right? And so there's no question in my mind if this is causing that, but I guarantee you there are so many labs that will not score that, all right? Medicare does not recognize this, all right? And a lot of sleep doctors, no, let me rephrase that. A lot of doctors that practice sleep, at least to the degree of identifying clear-cut apnea, and maybe they had a little bit of training, enough to maybe qualify to sitting for an exam, and they passed the exam, and now they're at the mercy of their technician who really runs the show, and they just look at the reports and sign off on them. But they're not that involved in it. And the technician is not going to stick their neck out and call that, because the doc may say, wait, no, I don't really see it. It's not clear cut. So they're only scoring things that are black and white. And I'll tell you, when the American Academy of Sleep Medicine back in 2012 said that all sleep labs have to start scoring these more subtle events, there was a big political pushback by most of the sleep labs that said it's not fair to hold us to that standard because Medicare doesn't even recognize that. So they ended up splitting it and saying there's two rules, rule 1A and 1B, and you could still be an accredited sleep lab without scoring these more subtle events. It's a longer story, but anyhow, these are all examples. Here, another example. This is on another one of our sleep systems. Same thing. All right. So this is not new information. This is an article that I co-authored back in 1992 with Dr. Chris Young-Guilleminault, I did my training at Stanford, and I was at Stanford back in 91, 92. And that's where I learned about all this. And actually I took it upon myself to make the PES a routine procedure, because it was only done on select patients. And I wanted to improve the technology and teach the technicians how to do this so it would be done more often. So it became a regular procedure when I left my fellowship. Unfortunately, over the years and with changes that take place, it's not being done that much any longer at Stanford. And the question is why? It takes a lot of technical finesse to do this procedure, but once you do it on a regular basis, it's very doable. And I've demonstrated over my entire professional career that can be done on a routine basis. And patients, about 10% to 15% of the time will not tolerate it, and they'll take the catheter out. But you've got 85 to 90% of the time where they do tolerate it, and you get this additional information. Now, this is an article. This is from a patient. See, this is a paper polygraph. This is, I like this because it shows you how old this information is. This is a 21-year-old Marine that was falling asleep on the firing range with a machine gun in his hand. Some people would say, oh, he had narcolepsy. Well, when I examined him, he didn't have classic sleep apnea features, and he didn't snore, and we did a sleep study, and we put the PES in, and we saw increased effort leading to arousal, and he didn't even snore, but he had upper airway resistance syndrome. Wow. Anyhow, there's another paper polygraph. All right, so here's Nicole's study, all right? And using the current 1A scoring rules, where you can score a hypopnea without the desaturation, her apnea-hypopnea index was 21 episodes per hour. Wow. Using the old scoring rules, rule 1B, which requires a 4% drop in the oxygen saturation in order to score a hypopnea, her study showed an AHI of 0.4, almost zero, right? So it was normal. So-
I always think that's an interesting, completely different diagnosis from the exact same data, exact same sleep study data.
Right. So what you see depends on how you look. If you're going to look at it, tabulating those more subtle events, this is what you're going to come up with. But looking at the same data, we're using the older obsolete scoring rules, which a sleep lab can utilize and become accredited. They don't have to do the newer scoring rules. It would become normal, or it would be read as normal. Okay. So anyhow, so, that's what I wanted to show, there. I've got a few other slides, but we'll see what comes up in our oh, the PES. You want to see the PES being placed in someone? Here.
Yes.
Yeah, okay. Let me, this is,
It doesn't hurt. It just feels a little weird, just
Really?
from my experience.
yeah, so here. Okay. So you see he's got a straw and there's the catheter. And I mean that's the catheter, and that's it going into the nose. And here's a patient. See, she tolerates it just fine. And she was missed at another sleep lab. They did chronic fatigue syndrome, but she had a high arch palate, relative micrognathia, and narrow airway. So.
Fantastic. I am looking at our live here, and that's the only place I can see comments, but we have lots of comments. Anne has asked, can the diagnosis of UARS be related to any medical conditions other than airway compromise? That's the first one.
Okay, so by definition, it's a disorder of airway compromise. It's upper airway resistance syndrome. So the answer is no. If you don't have a compromised airway, you're not going to have upper airway resistance syndrome. Now, if what the person's really trying to ask is, are there other things that can cause daytime sleepiness that are not upper airway resistance syndrome? Well, yes.
Okay, question number 2. What is the most sensitive type of sleep study for diagnosing UARS?
I just told you guys, it's a study done
This one.
with the nasoesophageal pressure catheter. And what will happen when you start going around asking, a lot of people will say you don't need it, because all you need to do is look at flow limitation and you could identify it just as well. And that's not true. And I can show examples of that. Well, actually I did. I showed an example that had flow limitation on there and it didn't show the event, but clearly the PES did. Think of it this way. All of the other parameters are external monitors. If you're looking at flow at the nose, it's external. The PES is the only internal measurement. And flow limitation is not an objective parameter. It's a relative parameter. It's looking at the curvature of the flow curve and whether there's something called flow limitation. And even if you saw it, you don't know the magnitude of the obstruction. And there are people that will have flow limitation from increased respiratory effort and partial blockage. And with the arousal, it doesn't completely go away. So there still is obstruction even with the arousal, but maybe to a lesser degree. So there's still flow limitation. And one of the things people are looking at with flow limitation is they're looking for the resolution of that flow limitation with the arousal. And when they don't see it, then they're skeptical that maybe it doesn't really, it's an artifact and it's not truly representing the airway compromise, because they're looking for it to resolve with the arousal. And it's a cheap man's method of trying to identify the underlying physiology. The PES is the gold standard.
Perfect. This question is for Nicole. How long have you or will you be with the MSE?
So it's almost complete, but they keep the appliance in for, I think the complete treatment is a year, because it's actual skeletal bone growth. We're not tipping teeth out so much as actually growing the bone at the midline palatal suture. So once the expansion's complete, they do, at least my orthodontist does Invisalign to pull the teeth together, straighten the teeth out, and the MSE appliance stays in the palate while the bone, because there's stem cells at the suture, and bone will grow to fill in that space. So now you actually have more bone, a real true increase in nasal floor volume and palatal width. So to answer, I believe a year is like the complete treatment. But you stop
Very
expanding after a certain number of turns. I'm almost done with the expansion part.
What was your molar to molar width before?
So we definitely don't want to measure out the molar, right? Because teeth are tipped out. So look at the gum line, and I believe it was 34 or 33. But my
I'm
teeth
right there with you.
woo,
32,
narrow
33.
palates. But the teeth, right, can be really tipped out. So if you're measuring at the cusp of the molar, you're not getting an accurate measurement of the skeletal bone.
Yeah.
Yeah, so I was definitely on the narrow side, and I had no idea, and I never had expansion as a child, which probably should have happened.
Perfect. Somebody said, Kate, how can you find MD sleep providers or sleep centers who understand to look at this in Texas?
Well, one good thing is that we provide telemedicine services now. So we're seeing
Awesome.
patients. Actually, I got an email today from someone in Italy, actually, who wants to fly in from Italy for the study. And we have patients, I mean, Nicole sends me patients that come in from, California. She actually also has patients from around the country as well. But we have patients that come in from out of town. There are very few facilities that are doing the esophageal pressure monitoring. And it's not to say everyone needs that. So I encourage someone to try to seek out help locally. But when they clinically feel that they have an airway problem and the response that they're getting from their local sleep doctor is no, you don't, then they should trust their gut. And they could even challenge the doctor that they're seeing about, well, how are you scoring? Are you scoring with the rule 1A versus 1B? They still might tell you yes, but but the issue is, what are the symptoms to suggest that there's airway compromise? So it's hard to find the University of Michigan, they'll do esophageal pressure monitoring. Dr. Ron Chervin, he runs the department over there at University of Michigan. He did his fellowship a year after me at Stanford. He's written extensively on PES monitoring, a number of years ago. I wish I could say Stanford still did them. I mean, it's a big to-do for them to do it now, and because it's not done on a regular basis. So it's hard to find. Not everyone has the same perspective, unfortunately.
Is narcolepsy genetic?
All right, so good question. So what we're learning more about narcolepsy is that one of the causes of narcolepsy may be from an autoimmune phenomena, that you're making antibodies that will attack the neurons in hypothalamus that make a neuropeptide called orexin or hypocretin. It's the same, it's two different names for the same neuropeptide. And there's a small number of neurons that make this orexin compound. And there are people that have HLA, which are markers on lymphocytes that you get genetically, that those markers seem to tie into those people that might have an autoimmunity for knocking out those neurons, because there's maybe some relationship to those markers on those lymphocytes, maybe similar to some of the markers that are on those neurons in certain people that have what we call HLA typing for narcolepsy. So then if that individual develops a particular kind of infection, for example, against strep, or let's say against the H1N1 flu, the antibodies that your body will start to make, some of those antibodies will actually go after those neurons and it will wipe them out. So it's so your body is attacking itself in response to an infection. And once those neurons are gone, they're not coming back. And now that person may have narcolepsy for the rest of their life. Wow. So what was demonstrated years ago when there was an outbreak of the H1N1 flu, individuals that either had the flu or were vaccinated for the flu had a higher likelihood of developing narcolepsy. I mean, there was a big spike of new cases of narcolepsy that came out, and those individuals were HLA positive for the markers. And that sort of, sort of really helped to solidify this concept that a lot of people that have narcolepsy may have it from an autoimmune disorder, and because they have a marker that predisposes them to having that autoimmune
and then something triggers. Wow. I know, oh my goodness, I have so many questions, but can you talk, you guys both talk to us a little bit about CAST, which is Children's Airway and Screener Task Force.
Okay, so, all right, so the American Dental Association came out with a position statement back in 2017, saying that all dentists should be screening for sleep disordered breathing, and then providing treatment when appropriate. And they didn't really give guidelines as to how to screen, and they basically realized that that putting it out there as a position by the ADA was going to stimulate a lot of more recognition of the airway problem. When it came to kids and pediatrics, there's really very little guidance. So Dr. Steve Carstensen put together a course with the ADA back in 2018, where they were going to talk about pediatric sleep apnea, and the day before the course, he invited key leaders in the field to sit around in a round table. There were about like 30, 40, 50 people maybe in this room, and to discuss the issues of pediatric sleep apnea. And so, there was a lot of discussion, and one of the results was the development of certain task forces, and one of those is the task force on screening. And I was appointed the chairman of that task force. And so it's and it cast for Children's Airway Screening Task Force. So we've now spent, and seeing Nicole's enthusiasm in this field, when we were first getting this thing started, I asked her to participate. She's been a great asset to the task force. And there's about 20 of us that are on the task force, and we were meeting regularly, and our efforts were slowed down because of COVID. But basically, we started working on coming up with a way of screening kids that can be done on a national level. And then at the same time, the ADA was given a mandate to come up with a screening protocol for kids. Well, since we already were working on our effort, they considered having our effort become adopted as their effort. And we actually did a presentation to them, to the ADA back in April of this year. And they then voted on, after hearing what we're doing, and basically sanctioned our effort as now it's an ADA effort. So I'm now a consultant. As a neurologist, I'm a consultant for the ADA.
That is fantastic.
Yeah,
a lot of stuff.
But what the point is that we're trying to, so CAST is coming up with a screening protocol, but the concept here is that we have a real simple 5-question screener, and we're in the process of looking to validate this protocol, and we're looking to get funding through donation, which is something that if you want more information, we can provide that. We're really hoping to get funding. But the thing is that we want a very simple, quick screening tool that can be, think of it as a big fishing net. And then you just go through and capture all these people. We want it more sensitive than what is going to be accurate. But now you can do a more thorough level of assessment on this smaller group that have now been positive with this simple screening tool. And you can now do a more elaborate. And then if there's still suspicion, then you go on doing a sleep study. But the thing is, if you're going to do a real thorough evaluation on everyone from the get-go, it's too cumbersome. You'll never implement it. We're talking about a 5-question simple questionnaire that can be administered by every dentist to every pediatric patient throughout the whole country, and maybe even have it something simple enough that can even be administered in the schools. So
Amazing.
a very simple thing. And then if it's positive, that just means that there's a need for doing a more thorough evaluation. So it might be that 20% of kids might need a more thorough evaluation. That's fine. At least it's not 100% of kids. And that more thorough evaluation might be just a longer screening questionnaire that might take 20 or 30 minutes to fill out instead of 3 minutes, right? Or it might take certain features on the examination. But then if that assessment still is positive, then it goes on to getting a sleep study. So we're looking to validate this. And right now we have, so we're looking to put this into the hands of, for the validation study, to do 10 different institutions across the country. And we're going to have the screening done in dental offices, and then the sleep studies done in pediatric sleep testing facilities. And we're going to validate this. And then once we've done that validation, it's going to be promoted across the country and even internationally.
Amazing. I do have a question. Any recommendation to have the child do a full myofunctional therapy evaluation if it's positive?
Well, yeah, that is clearly going to be helpful, because a myofunctional therapist is going to look at a lot of the subtleties, and a lot of times the dentist may not have the time, and you can't just have the hygienist do it if the hygienist isn't trained. So yeah, that would be worthwhile. But let's talk for a second. Why do we want little kids to be identified? Well, if you can identify this at an early age, then you could intervene orthodontically in a much easier fashion than what Nicole is going through right now. And the idea is that you can change, because it's not about the teeth, it's about the skeletal structures of the airway. And so and they're more malleable in these little kids. So if you can intervene with orthodontics in the little kid, then you're going to maybe prevent a lot of these issues later in life.
And intervene with myofunctional therapy early to help facilitate proper orofacial growth, to even lessen the need possibly for the orthodontic portion as well. So
exactly.
Yeah, I'd like to show real quickly, if I can, because I know we're running out of time. I'm gonna share my screen for 1 second here.
We could do another hour, right, guys?
Okay, are you able to? Here, can you see my screen? There.
Yeah.
Okay, so the AAPMD in September 23rd to 26th. That's going to be a great conference in Atlanta. And so I want to make sure people are aware of that. Okay, so the Sleep Education Consortium, it's going to be in Houston, January 27th through 29th. And again, it's hands-on part of the course. There'll be topics on many different aspects of sleep disorders, but with a high emphasis on airway and dentistry. But we also cover narcolepsy, restless legs, insomnia, things of that nature. And so if you want more information, you can send an email to info@sleepeducation.net. That's the email for the Sleep Education Consortium. You could go to the webpage, which is dentalsleepconference.com. But I really encourage those. We had a lot of myofunctional therapists. Actually, we had Joy Moeller was our lecturer last time we did this, right before the pandemic. And then my webpage I mentioned, so we have www.csma.clinic, and we do telemedicine, and there's a lot of information on our webpage. You might find the TED Talk that I did very intriguing. I talk a lot about airway compromise and some of the consequences when that's not identified properly. But
I will put that on our Facebook page.
Oh, great.
I'll share that there. But thank you. Dr. Ella Otis is watching. She says she cannot wait for this tool that you guys are having come out. This has been fantastic. And I think we could go for 3 more hours because we have so much to talk about. But we're going to have to schedule something else to cover sleep disorder breathing, a little bit more UARS.
And next time we'll cover bruxism. Look at that. Yes, what a big topic that we didn't get a chance to talk about. Sleep bruxism.
Each one of these topics could be its own event over here. But I only have love for both of you, and I am so grateful that you took time out of your Friday to be here and to share so much with us. You know, in Airway Circle, we are huge about bringing awareness and collaborating with other providers and talking about the importance to respecting everybody else's specialty and understanding that we all see the patient with different eyes. So if we work together, we're going to be able to help a lot more people. So thanks so much. Guys, make sure that you join our Airway Circle Facebook group, the private one if you are a professional. We have clubhouse meetings Tuesdays, Wednesdays, Thursdays, and Sundays. Anytime, you don't have to attend all of them, whatever you are, whenever you are available, you can join on Tuesdays and Thursdays, 8 p.m. Eastern Standard Time. On Wednesdays, it's hosted by Dr. Martha Cortez at 5:55 p.m. And on Sunday, it's hosted by Dr. Jasmine Elmore at 1:30 p.m. And on Fridays, we have amazing speakers like these that we get to share, and these are recorded, so you guys get to watch it later. Any last words, guys?
Oh, thank you. It was fun. It was a pleasure to be here. And I like to spread the word. I mean, the information is no good if it just stays in my head.
Right. Yes.
I feel like we need to come back on and do more because it's so just exciting. There's always more to learn. I get the chills like when we're talking about it because it's I'm so into this. It's so great. So thank you for spreading all this information and helping everybody learn about this topic.
Of course. Thank you. Thank you, guys. Have a wonderful weekend, and we'll see y'all next week. Bye-bye.
Take care. Bye.